Hi, my name is Dr. Abbie Najjarine. I'm a podiatrist from Australia, Sydney. Today we're going to discuss about how to mobilise and adjust the feet. Now there are 26 bones in the foot and 2 sesamoids, which make it 28. And there's so many joints in the foot that needs to be congruently working together and allows the foot to function in a better way when the foot's being mobilised. Now it's important when using orthotic therapy and mobilisation together. I think my patients actually improve quite dramatically with both together, that alignment together. What we're going to do is go through step by step, adjusting the calcaneus, the navicular, the cuboid, the cuneiforms, the tarso-metatarso joint, the metatarsophalangeal joints and the phalanges, and then the ankle joint. Then we're going to go to the knee and then the ball and socket and the hip joint. Alright, we're going to demonstrate first the calcaneal adjustment. So what we do initially, we circle the foot to loosen up any adhesions or scar tissue that's holding the foot together. Just circulate it back and forth, maybe about 5 to 10 times, depending on the patient's foot structure. Make sure that when you're doing somebody with rheumatoid or osteoarthritis or they have osteoporosis, you have to be very, very careful. The osteoarthritis is okay to do, but you have to be gentle with them. Rheumatoid arthritis, you feel a tearing effect rather than an adjustment. So you just have to be very, very careful. It doesn't mean you can't do it, just have to be very, very gentle with them. The advanced cases of this, I would advise not to do it. Psoriatic arthritis is another one you have to be very careful of, probably not to do it at all. Now, on the top of the foot, circulate again, then use your 3 fingers to grab the calcaneus. And you're basically lifting the calcaneus with your 3 fingers. And on the front here, you dorsiflex and plantarflex the foot about 20 to 30 times, very fast. And you feel there's a restriction, keep going with it. If you feel that, look, the foot's a bit mobile, you can go to the next stage. So you drop the foot down, and you allow about 2 inches away from the bench, from the malleolar position to the actual bench is about 2 inches. You get your thumb, you grab your thumb and you hold the malleola on the inside. Middle malleola is held on the inside. You grab your index finger and your thumb, you wrap around the heel. Make sure the bench is the right height for you. Now, what we're doing here is we're going for the full range of movement first, before we thrust anything. Going for the full range, holding it, make sure the patient's comfortable, maybe get reassurance from the patient, and then you say to them, you might feel a click or a clunk, just relax and go all the way through and until you thrust it in like this, like that. Okay, now his case, his heel was in position, but there was a slight movement. You can go again if you feel like there's something locked up, and the patient will tell you, I feel like it needs to go. You just have another go at it, like so. Now, you've done that, you go to the navicular, sits right there. You invert the foot, so which means you grab the forefoot area and you invert it in that position. You grab your thinner eminence, your hand, your palm of your hand, you place it on the navicular, your fingers just hold around the heel, like so. Your wings are out, you go all the way, make sure your thumb supports the lateral side. You don't want to end up injuring the lateral side of the foot. So you hold the support the lateral side, your thumb goes across the arch, your fingers go around the heel, and we get your wings out, and you thrust in that direction. It just went now. Just a slight movement, and it adjusted immediately. Sorry, went laterally. Now, the cuboid is a tricky one. You have to place your hand, your thumb and index finger around the lateral malleolus, across the foot like this. You evert the foot now. You evert the position of the foot, and you're actually thrusting in that direction. And you wiggle around a little bit. If you find it's hard, we've got a supinated foot structure, you bring the leg out a little bit that way, and you go all through the range, for the full range movement first, and then you thrust again. And if you heard that, it just adjusted. Now, the cuneiforms, you don't get much of an adjustment in the cuneiform, but it can be painful in this area, the cuneiforms. You start from the medial side, and you place your thumb, and you push with the forefoot in a plantarflex position with the other hand, and you go to the middle, and then you turn your thumb slightly on an angle, like slightly on an angle, so you're actually piecing the side of your thumb into the side to get to the middle cuneiform, and you a thrust in that position too. So you're pushing it into dorsiflexion while the forefoot is being thrust in a plantar flex position. You've done that, you come around to the tarsometatarsal joint. You place your thumb in that area here where the heel finishes, and you place your thumb and hold it really firm around this area. You hold the first metatarsal phalangeal joint and you rotate until you get a rotate forward, and then you rotate back and rotate forward and then up and down. And a lot of them say to you, I feel locked up in that area, I need that freed up. And you just keep going with it until it frees up, and you hear some clunk action occurring, and you know you need to keep going with it. Sometimes we use dry needling in that area to free it up and do it again. The metatarsal phalangeal joints, this area here, you place your thumb on the metatarsal head. The digit is being forced into plantar flexion. As you heard that, the second one, there he goes. And then all the way to the second metatarsal head. The first metatarsal, you do not do that. It doesn't like that action. So what we do with the first metatarsal is pull it. And this one's the same. This one's the same. So pull the phalanges in that direction. Now, if someone has sesamoiditis, it's very painful, but you grab your thumbs. Sometimes the sesamoid slides laterally. So you grab your thumbs and you feel the sesamoid, and then you force it into a medial direction, in that direction. You don't have to do that. Only if people suffer with sesamoiditis you do this. Now, I'll get you to turn over. This one here is the ankle joint here. You grab the ankle joint, like so, and you thrust in that direction. Thrust in that direction. Now, when you come to the knee, you turn the knee all the way in. You find the fibular head. Find the fibular head, and it sometimes it's quite tender in this area. You place your palm in that direction. Your fingers just roll over the knee, okay? You turn the leg in, and this one really just supports, this hand just supports that area, and you're actually thrusting in that direction. And sometimes what they call is a lateral displacement of the tibia, and you can actually see that on an x-ray. So the tibial condyle could be laterally displaced, so all you're doing all the way through, and you thrust in that direction. And do it again, once or twice, and you grab the leg all the way up, grab the knee. Now you're looking at the patient initially, you end up 90 degrees in that direction. So you start from there, and you turn around to 90 degrees in that direction, and while you're rotating, then you're thrusting in a downward direction like so. And that should sometimes give it a clunk. There is one technique I didn't show. Can you lie on your stomach again? Is the ankle joint, which is an important one. After you finish the phalanges, you grab the toes in that position, you grab the heel, the outside hand grabs the heel, inside hand grabs from the ankle joint, the top of the foot, and you pull and lock in that position. So you're actually shifting the tailor going back into the right position. Pulling up and pushing in that direction, do about 3 or 4 times. In this case, it's fine. Now, there's a clunk, a snap, a pop, and a crack. All mean different things. A clunk is a joint realigning. A snap is a tendon slipping back into position. A pop is the gas releasing in the joint. And a crack, you don't want to go there. That's when the bone's broken. And people hear about that crack. Thank you.